Palmer and the committee for the invitation to come and speak to you today. Thank you to the Boyds for that powerful story. I think it's stories like that that drive us and inspire us. Um, I'm an emergency physician and I research cardiac arrest and out of hospital cardiac arrest particularly, and I'm particularly interested in how to engage the community more in the response to these emergency events. Not an easy area to work in, and I think we've heard some of that, the engagement piece and getting people to listen is very difficult. Amr asked me to speak today about public access defibrillation. I understand that we're focused on the athlete and sport, but as you know, sports and athletes exist within our community at large. And cardiac arrest is certainly a public health problem that's beyond just the halls of our athletes and our sports facilities. And I think it's important that we consider the greater context of out-of-hospital cardiac arrest as we consider the athletic events that are happening within our communities, and it'll help us think about solutions and approaches for the problem that we're interested in. So in the next 15 minutes, I'm going to move quickly. I'm going to talk about the importance of early defibrillation for out-of-hospital cardiac arrest, some barriers that we know about, and some novel approaches to public access defibrillation that might inspire us, again, to think about the athletic scenario specifically. So this is data that's confirmed by more recent research from the Heart and Stroke Foundation of Canada that's yet to be published, but we anticipate that every year in Canada there will be 40,000 out-of-hospital cardiac arrests a year. And only 10% of these survive, unfortunately. Mr. Boyd just mentioned this relationship, which is always a bit shocking to those who haven't thought about this before, but for every minute that passes that neither CPR nor defibrillation is happening for someone in cardiac arrest, the probability of survival is dropping by 10%. So this is a quintessential, time-sensitive emergency for patients who experience this. And put that in the context of our optimized urban EMS systems in North America, report through the Resuscitation Outcomes Consortium that the median time from 911 call to arrival of our ambulances is about 8 minutes. So of course that means that half the times are greater than that, and this data is coming from the best of the best in North America. So certainly there are many places where response times are much longer than that on average. So when you put those two figures together, 10% per minute, and we have to wait 8 minutes plus for our experienced providers and defibrillators to arrive through the 911 system, we have to focus on the community response. And this statement is certainly true, that when we have cardiac arrest occur in the community, we have to depend on the community. This is not a problem that will be solved by phoning 911. These three first steps in the chain of survival are key. And if these don't occur, early recognition, early bystander CPR, and early bystander defibrillation, these later links that occur with our professionals who arrive on scene and then care in the hospital make very little difference as far as survival advantage. So we have to emphasize our efforts on these first links in the chain of survival if we're going to improve survival from cardiac arrest. So of course, we're focusing in this talk on defibrillation, but of course we have to think about CPR and defibrillation as a unit of treatment. But since the 80s, we've had technology allow us to bring defibrillation into the community. And we're all familiar with AEDs. I want us to think of them not as simply defibrillation tools, but they're really resuscitation coaches for those who are not very practiced or knowledgeable about CPR, or may have never done CPR before. Some of the contemporary units available on the market can coach you through the steps of responding to the emergency beyond just defibrillation. And some like this will even have feedback devices to coach the uninitiated on whether the chest compressions they're providing are adequate, and tell them to push harder or faster based on what we know as the best rates for CPR. So of course we've seen these proliferate. These devices have certainly gone up and up and up in numbers. They're everywhere in public settings, although it seems like it's certainly when you're walking around and if you're thinking in this field, you see them everywhere. And sometimes everything aligns and beautiful things happen when all the pieces of the puzzle are in place and things align. This is an example from Toronto. This young woman was on the subway going to work. She suffered a cardiac arrest on the subway, and the conductor stopped the train at Pape Station, got out, got the defibrillator that was at the ticket collector's booth, applied it to her, and she was shocked successfully. She survived and then delivered a healthy baby a couple of months later. So this is, you know, the kind of things that we can do when the knowledge is there. They can retrieve the AD close, get it on quickly, and make a save. And we know from data, the best data that we have, which isn't perfect, things like the PAD trial and also observational data from the Resuscitation Outcomes Consortium, that public access defibrillation programs can double or triple the odds of survival for patients who arrest in those communities where public access defibrillation is available. And in some special settings, this is a famous study from early 2000s called the Valenzuela Casino Study, where they trained security officers in Las Vegas casinos to recognize and respond to cardiac arrest. And of course, when you're in the casino, you're being observed the whole time. So people who collapse are recognized very quickly. So they set up a local emergency response protocol in the casinos, and under those settings, witnessed patients with ventricular fibrillation treated by security guards had a survival rate of 74%. So of course, compared to the wild type, out in the wild, cardiac arrest in the community surviving 10%, in a special scenario where we can get the defibrillator on the chest very quickly, we have the opportunity to have these impressive survival rates. And I saw data today presented earlier with 94% survival rate from Dr. Pipe, 100%. Amazing. So of course that's the goal, is to turn the community into a casino or a Japanese marathon as far as recognition, rapid access to defibrillation and survival rates, mimicking these special scenarios. But here's the problem. Right now in private settings, so in residential settings, there's probably closer to 0% use of public access defibrillation. That makes sense because we focused our efforts on putting public access defibrillators in public settings. But the fact is that 80% of cardiac arrests occur in residential settings. If you look at public settings, so outside of residential settings, the usage rate for AEDs in cardiac arrest is about 15%. And this is AEDs before the paramedics arrive. So better, but certainly much room for improvement. So the question is, what's the problem? What are the barriers? This is, I spent a year in Edinburgh last year on sabbatical, and I saw these defibrillator boxes everywhere. And I don't know if you can see that, but there's a keypad on them. So to get into this public access defibrillator, you need to have the combination to get in so that nobody steals the defibrillator. And that kind of blew my mind that was in place. There's been a lot of work, mostly qualitative work, on looking at barriers and facilitators to public access defibrillation. This is a great summary of that research from Chris Smith and Gavin Perkins in England. And there are a lot of barriers identified. Some of them are listed here. Some of them make a lot of sense. Some of them are probably more important than others, and they're probably setting specific. But when I read about all these, and when I think about the problem in speaking to people and looking at the data, I think the fundamental underlying problem is that our strategies to date have not considered in their design that we have to bring a person and a defibrillator to the patient. We can't consider them as separate things, because if they don't arrive together, the patient is not going to be defibrillated. So traditionally, we've sort of focused on putting defibrillators in the community, and then we've also focused on training individuals in the community, and then hoping that at the time we need them, those two things are together. But we haven't designed our systems and our response to do that, and instead we've relied on luck, really. We've just put those two things out there, and we hope that somebody arrests near a defib, that one's available, and we hope that somebody's willing, trained, and able to do it. And unfortunately, that's not happening most of the times. resulting in the numbers that we see of 3% public access defibrillator use in out-of-hospital cardiac arrest. So some of the new approaches and innovative approaches to public access defibrillation deal with this and have that dyad of the rescuer with the defibrillator more front and center. So I'm going to talk about a few strategies that fall into these main categories. So improving PAD by ensuring that public access defibrillators are in places where the arrests are most likely to occur. Other strategies which support this formation of the person and the defib, not just one or the other. And then strategies that look beyond just static defibrillator placement, sticking on at a wall in a rink. So I'll just give you some examples of some things that we are working on and others are working on. This first item here, making sure they're where they're needed most. So we did a little bit of work looking at building types, and a lot of other investigator groups have done this. Our data set was from Toronto. We had thousands of out-of-hospital cardiac arrest in public settings, and not a surprise to many, things like airports and convention centers came up, but a surprise to us was hotels and motels. I think maybe because of the number of people hours that are spent in these places. We don't just pass through them, we stay in hotels and sleep, and maybe it's because of some things that are happening in hotels, I'm not sure. But as well, prisons came up. And these are, I think, under-recognized locations that were surprising to us. We then looked at sort of the risk, rank order risk by building type, and lined it up with the rank order risk of AED placement, not risk, but the incidence of AED placement by building type. And we found they were terribly mismatched. So we focused a lot on putting AEDs in schools. And I don't want to say that that is a bad idea and there aren't benefits to doing that, but just to say that the risk of cardiac arrest in schools is lower down on the rank order list of risk, but highest building coverage in Toronto as an example, whereas other high-risk locations like hotels and motels in Toronto are very poorly covered with defibrillators. I would challenge anyone in the room to tell me where the closest defibrillator is in this hotel. I don't know if anybody knows. So I'm hoping I don't go down right now, knock on wood, because I doubt that I would get a defib on me before paramedics arrive. We moved on from this work looking at building type to actually looking at the geographic distribution of arrests and saying, why don't we put the defibs where the data actually shows us the risk are, using historical cardiac arrest distribution to predict future risk. And we did some work showing that the distribution of cardiac arrest is actually stable over time, probably predicted by people flow, population density, and demographics, and activity type in certain locations. This is Toronto with the cardiac arrests mapped in red. The blue dots are the defibrillators, and those green little crosses are where an optimization model using those pieces of data suggested that we put the next AED. So without going into details of the research, it's the idea that we're using evidence and data to drive where we put defibs, not simply handing them out to whoever wants them. The same kind of work in Toronto showed us that half of our defibrillators were inaccessible after business hours. Like a full half of them are behind locked doors after about 5 p.m. The gray shadow area shows the proportion of buildings that are open and accessible where the defibs are by time of day. And the first 5 peaks there are weekdays and then weekends on the far right. So it's just a recognition that our public access defibrillators are not really publicly accessible for a large portion of the day. We did research looking at what type of buildings should be, or places should be putting defibs in to maximize temporal access and also maximize location near risk. And it turns out that ATMs and Tim Hortons in Canada are placed, probably driven by economic reasons, putting them where there's population density, but also these are 24-hour places which are heated and observed if you're worried about theft of your defibs, but they might be places to consider. So again, the idea that instead of just randomly putting them out to whoever wants them, thinking carefully about risk and access. In Europe, they're leading us with putting defibs outside. So getting rid of the locked doors, making them much more visible, using heated boxes monitored through the internet. So these are just some things to sort of make sure that the defibs are in the right place and available at the right time. Moving to strategies that look to support this idea of getting the person and the defib together, just wanted to briefly highlight the PulsePoint app as one example of many mobile apps available around the world now, which link with 911 services and volunteers in the community who are either verified or self-proclaimed they're trained in CPR to pull them into an out-of-hospital cardiac arrest emergency that's called into 911. So essentially adding a layer of dispatchable assets in addition to paramedics and firefighters. You're adding a volunteer layer that's connected to 911 through their mobile phone. So we've implemented this here in Kingston. Essentially, you put some software in the computer-assisted dispatch system, you promote the app to the community, and you get as many CPR trained people in your community to upload the app onto their phone. You then have this army of responders. This is in the San Francisco Bay Area where they started this idea, and this shows every yellow icon as a person with the app on their phone ready to respond. When a cardiac arrest happens in one of these PulsePoint activated communities, there's the CAD system and the PulsePoint software essentially set a 400-meter radius and find any app users within the radius and send them a direct notification to their mobile phone, which includes a text-based, address-based notification, and then a map-based directional advice to get to the cardiac arrest and to get to the defib. Systems in Europe have gone one step further, dividing the available rescuers up, some to go get the AED and some to go start CPR. And certainly as the tech and the software advance, there's more and more features. This is an alert I received in my office at Botterill Hall on the university campus. And this was turned out to be a syncable event. You can imagine there's lots of false alarms, but about 1 in 10 are real. But this was on my watch. I was writing a paper and my watch went off and I stood up and the event was outside my window. And I would have not been aware of that prior to the system being there. So certainly there's a potential for benefit. The evidence is thin. We have got a grant from CIHR and we're pursuing a randomized trial in the province of British Columbia, the city of Winnipeg and the city of Columbus, Ohio. And we're about to launch this fall. So we hope to provide some data on effectiveness. The third strategy, I'm almost finished here. I know I'm a little bit over time, I apologize, is getting rid of the idea that defibs have to be stuck on a wall and just sit. That we can think about mobile, non-static AEDs. This is an example in Singapore where they've paired an app like PulsePoint with taxi drivers, and they've equipped all their taxis with AEDs, and the taxi drivers will respond with paramedics to nearby cardiac arrest events, and I think there's even a payment to the taxi drivers for responding. This is a program in Scotland where volunteers within communities with traditionally prolonged EMS response times, which might be outside of dense urban areas, get trained in CPR, get provided with defibrillators, and then essentially take call in turns for their community. And they are dispatched in parallel, again, with paramedics to respond to cardiac arrest events. And then paramedics come and take over the scene as soon as they arrive. We're taking that concept and we've just submitted a CIHR application to pilot in 3 counties locally to recruit volunteers, provide them with AEDs, and dispatch them in parallel with paramedics. This is PulsePoint's concept as well, where these red icons are not just people with apps, but they're off-duty firefighters or paramedics or nurses or physicians equipped with AEDs that add to the PulsePoint responders. I think we're at a moment of potential disruption in the industry about AEDs. This is an Australian startup company. They have a prototype here that they're planning to sell for 150 Australian dollars, which is equivalent almost to our Canadian dollars. It's a disposable AED. It's meant for consumer use. It's about the size of a large mobile phone. Just weighs not too many grams. You can put it in your bag or have it in your house. I could envision it being sold next to the smoke detectors in Home Depot. It has enough energy for 8 shocks, and it's essentially disposable. It talks you through CPR like the other more conventional models, and it has a 2-year shelf life. So I think I'm working with them. They've got millions of dollars of venture capital. They're moving quickly to get their marks in Europe and working with the FDA and Health Canada. So we'll see this come very soon, and I think it could kind of revolutionize the model of public access defibrillation and talk about personal access defibrillation. And of course, drones, which maybe 5 years ago kind of got mostly giggles and other things and eye rolls from the audience. I think I'm still rolling my eyes. I'm a healthy skeptic, but there are people moving on this. Drones are coming, whether we do anything about it or not, and so they're going to deliver a pizza, and people are looking to deliver AEDs with them. Lots of regulatory and logistical issues, but people in our neighborhood here and around the world are moving forward in testing drone for AED delivery. And you can imagine how it might be grouped with things like epinephrine, Narcan, bleeding control, surveillance for mass casualty incidents. So you could imagine maybe a feasible system that was like a multi-use utility drone equipped with AEDs and could be tasked for emergencies. So I'm sorry I went over time there. Just to summarize, there's evidence, of course, that PAD programs can save lives, but unfortunately, we're just not getting penetration and real uptake. There are multiple barriers. They're very challenging, but there are novel approaches being worked on. I think this group here has an opportunity to liaise with other groups in Canada, the US, and internationally who are working on the problem of cardiac arrest in the community. And I see this as a very special and important subgroup in cardiac arrest in the community that has certainly specific needs and has special stakeholders, but I think the problem is universal. So we can combine forces to address the problem. Thank you very much.